Tonight is our virtual collaboration forum, sponsored by the Collaborative Mentorship Network for Chronic Pain and Addiction. And we're talking about health, harm reduction, and politics, what community providers need to know. My name's Kathy Scrimshaw. I'm a family doctor, and I have worked as a rural generalist down in southern Alberta.
You did that exactly wrong.
So welcome everyone to our session tonight. We do have a live recording here that you'll be used to seeing the notice. I'm Kathy Scrimshaw. I'm the medical director of the Collaborative Mentorship Network for Chronic Pain and Addiction, and I'll be your moderator. We have a great panel talking about health, harm reduction, and politics, what community providers need to know. If we can go to the next slide, please. We have just seen the film and the land acknowledgement, but I'd also like to acknowledge that we're webcasting from and to many different parts of Alberta today. The province Alberta is located on Treaty 4, Treaty 6, Treaty 7, Treaty 8, and Treaty 10 territories, as well as the Métis settlements and the Métis regions. And it's a traditional meeting ground and home for many Indigenous peoples. Please take a moment and reflect on what truth and reconciliation means to you, and consider some of the calls to action from the Truth and Reconciliation Commission of Canada and how you're going to act on those. Next slide, please. As I said, I'm Kathy Scrimshaw. I'm a family doctor down in southern Alberta. I am a paid part-time employee of the Alberta College, and I also work in the Indigenous Wellness Corps for Alberta Health Services. And I just want to mention that this session receives financial support through the Alberta College of Family Physicians from a Health Canada Substance Use and Addictions Program contribution. It does not receive any in-kind support. Next slide, please. So we'll get on to our panel. I'm going to introduce all three speakers. We have a lot of information to go through, and we want to leave time for some questions. I know we had a bit of a glitch getting everybody in, and so I will shorten our introductions here, but I do want to welcome Dianne Dyer. She is a registered nurse and retired a couple of years ago, but her idea of retirement isn't what everyone else is, and she's a very active volunteer, and she's chair of the board of SafeLink. She has been instrumental in the Alberta Health Services harm reduction policies, as well as in the establishment of IOT, which is injectable opioid agonist treatment clinics. She has many skills, and she'll be reviewing harm reduction from her lens as a policymaker, as a harm reduction advocate, and as a very qualified harm reduction nurse. Our next two speakers are, next slide, please. Jessica Kirkwood, who is known to many of you. She's a family doctor who has worked, is working at Radius Community Health and Healing, the former Boyle Macaulay, and she is a peer team member, very passionate about educating primary care providers and learners to care for marginalized patients in a way that's empathetic, evidence-based. She has two kids, a fluffy dog, very patient partner, and she'll be reviewing how to incorporate harm reduction in your regular practice, as well as some of the common concerns she's seen. And then finally, we have Dr. Kristy Sutherland from British Columbia in Vancouver. She is a family doc and a diplomat of the American Board of Addiction Medicine, and she works in Vancouver's downtown east side. She's the medical director of the Portland Hotel Society, and she leads a team of physicians and nurses who are embedded in low barrier harm reduction projects. She also was the British Columbia Family Physician of the Year in 2018, and she's the recipient of a City of Vancouver Award for Excellence in 2019. Kristy will bring a wealth of information from another province that also has been working a lot in cutting edge harm reduction. So Dianne, I'll turn it over to you.
Well, thank you very much, and I'm very pleased to be here this evening. And what a wonderful opportunity to present to you. So the only potential conflict of interest I have is I'm currently chairman of the board of SafeLink Alberta, which was mentioned just a few minutes ago. Next slide, please. So the goals for the presentation is to define harm reduction for you, talk a little bit about the potential benefits to the individuals in the community, give you some harm reduction examples, and talk a little bit about the injectable opiate agonist treatment program and supervised consumption services. Yes. And I'm going to look at policy work and the focus of that, implementing harm reduction in primary care, patient advocacy, and lessons learned and messages from patients. Next slide, please. So what is harm reduction? So when we define harm reduction, we're talking about policies, programs, practices that aim to reduce the adverse health, social, or economic consequences of the use of psychoactive substances without reducing consumption. Abstinence, as you know, is not always a realistic goal for some people. However, the goal is to prevent harm that can result in injury, disease, substance misuse, overdoses, and death. Harm reduction is a vital step along the continuum towards recovery-oriented care and support. Harm reduction is about more than supervised consumption. It's about building good, strong, trusting relationships and accepting and meeting people where they're at without tension. Next slide, please.
Dianne, it's Kathy. We're just having a bit of trouble hearing you. I don't know if you can get closer to the mic.
Sorry. Can you hear me better now?
Yeah, I think it sounds a little bit better.
Okay, sorry about that. Okay, so this particular slide, this quote is from Dr. Wakeman. This was found on Twitter in November 2018. And what she said is that harm reduction could be summarized as meeting someone where they are, but not leaving them where you found them. Harm reduction is based on the premise that each person is the expert in their own life. They must play an active role in developing a plan to implement change. Next slide, please. So what are the potential benefits for the individuals? Research shows harm reduction activities can restore a sense of dignity, self-worth, and hope, reduce HIV infections and hepatitis and other bloodborne infections, promote access to evidence-based education on safer practices, reduce overdoses and other early deaths, and increase access to health, social services, and recovery-oriented treatment options. Next slide, please. So how does harm reduction benefit the community? Well, research has shown that we can decrease costs to healthcare, social services, and the justice system, increase general public education on safer practices and ways to access harm reduction programs, decrease stigma and discrimination towards persons using substances within the community, and increase referrals to treatment programs and social services. Next slide, please. So let's talk for just a moment about the injectable opiate agonist treatment program. To be eligible, one had to be diagnosed with opioid use disorder and at high risk of overdose. Previous unsuccessful trial of oral OAT, patients administered their drugs intravenously and often long-term use. Patients were prescribed and offered up to 3 doses of injectable hydromorphone daily, administered under RN supervision, and a long-acting oral opioid at their last appointment to avoid withdrawal symptoms overnight, such as a slow-release oral morphine. All patients were offered compassion, a safe place, specialized evidence-based treatment, primary care, psychosocial supports, social supports, and referrals as needed. Unfortunately, new admissions were discontinued in January 2020. However, after a successful court challenge, 100 patients that were in the program were allowed to complete their treatment wherever possible. Next slide, please. So what did the patients tell us? They said this was a life-saving treatment. They were treated like a person with dignity. They built positive relationships with healthcare providers. They found meaning in their lives. One patient said, "My health is huge. Number one change. I've got more energy, more strength. From before, I didn't even want to get out of bed. I didn't even much want to live. Waking up and wanting to wake up and go through the day is amazing." Another patient said, "I've had years of poor experiences with doctors before this. The biggest plus is that I feel like I'm treated like a person that people care about, treated with dignity, and they see my strengths. This place has helped me find meaning in my life." Next slide, please. So we did an evaluation buyout, and here's some of the findings. 41% of respondents at the start of the program found their quality of life to be very poor or poor, and more than half, 55%, were dissatisfied or very dissatisfied with their health. After only 2 months and a little longer in the program, 69% of respondents indicated their quality of life was good or very good, and 48% were satisfied with their health. No one died at the site from opening date to January 2020. Next slide, please. So let's talk a little bit about supervised consumption services. This is a safe, supportive environment for clients to use drugs they have acquired in the community while reducing the chances of a poisoning death. Access to harm reduction supplies is available, decreasing the transmission of disease and infection. And it's a unique opportunity to build trust with a healthcare provider and to connect to additional services and community-based services. For example, the supervised consumption site at Sheldon Schumer was identified as the #1 referral source for the injectable opioid agonist treatment patients in Calgary. And here's some past statistics. In Calgary, the supervised consumption services site opened in October 2017. As of March 31st, 2019, the site saw 71,096 visits, provided 863 referrals to other services, and reversed 954 overdoses. No one died at the site. Next slide, please. So let's talk about some myths related to harm reduction. One of them is that people have to hit rock bottom before they can be helped. Well, the fact is, hitting rock bottom does not help most people and can be clearly destructive. Harm reduction focuses on building relationships with people that are safe, trusting, and compassionate. Once the person feels comfortable, they are more likely to ask for help. It is an open door to address concerns as patients see fit. Trust can be built with time and with respect. Next slide, please. Another myth is that detoxification is the answer to solving the crisis of addiction and overdose deaths. Well, the fact is, detoxification alone can actually cause harm, especially with opioid use disorder. Studies suggest that opiate agonist therapy, a form of harm reduction, is more effective than withdrawal management alone. It is essential that individuals are offered various social, psychological, and other long-term supports to address their various needs. Next slide, please. Another myth. Stigma is a state of mind and does not really impact the care of the patient or the outcomes. Well, the fact is, stigma from healthcare and social services is a major barrier to accessing services. It reduces the quality of care and makes patients less likely to follow through on treatment out of fear they will face stigma once again. The judgment and fear associated with identifying yourself as someone who uses drugs pushes people to use in isolation, where the risk of death is far greater. Ultimately, stigma can kill. Next slide, please. Sean Falker, in December 2018, stated that stigma is lethal. As a professional in long-term recovery, I know this struggle well. Until we feel safe disclosing our struggles without fear of shame, stigma, isolation, and career suicide, this pattern will repeat. It starts with us.
And the last one is 7.
So Sean was using substances in the past and chose to seek treatment. He is now a physician working with clients in recovery. Next slide, please. Another myth is people can always choose to stop using substances. It is a case of willpower. Well, the fact is, addiction is not a choice. The brain physiology changes, and these changes impact thinking that drives repeated use in order to avoid the terrible symptoms of withdrawal. It takes time to recover from and is difficult to do without support and management of those withdrawal symptoms. Next slide, please. Another myth. It is your professional responsibility to inform the patient of your and ensure that they are on the right path in their life. The fact is, as a professional, it is your responsibility to follow your code of ethics and treat all patients with respect, dignity, and without judgment. However, we acknowledge that this is not an easy role in practice, and you may need to seek support and guidance from others in your team or externally. So don't be afraid to seek help and guidance if it's needed. Next slide, please. The final myth, harm reduction is expensive. Tax dollars are being wasted on harm reduction. The cost of treatment and emergency interventions, however, as a result of substance use and sexually transmitted and bloodborne infections, is far greater than the cost of prevention efforts. Now, an AHS board member commented at the time of approval of the harm reduction policy. He said, "It does not cost anything to be kind." Next slide, please. So when we talk about policy work, what is the focus? It's to clarify the responsibility of the healthcare providers to provide patients who use psychoactive substances with evidence-based, equitable, non-judgmental, compassionate, and family-centered care, and to offer direction in program planning and service delivery within the organization built on the harm reduction approach. Now, to create the AHS harm reduction policy, I facilitated a group of clinical experts from acute care and the community, persons with lived experience, and experts in policy work. Once the policy was developed, the draft was circulated to key stakeholders, internal and external to AHS across the province for their feedback. We received over 300 responses, and over 95% of the responses were very positive, and we were thanked for moving ahead to develop this policy. It was approved by the AHS board and then by senior leadership. Next slide, please. So if you look on the AHS website, in the public section of the site, you will find numerous policies, and there's many that could help you in your work. There's one called Managed Risk Agreements, Naloxone Kit Policy, Psychoactive Substance Use, which is the previous harm reduction policy, and Residential Addiction Treatment and Detoxification, and many other policies are available to you, and they may guide your practice or may guide your policy work in your own organization. The focus on these particular policies is the affective domain, or changing values, beliefs, and emotions. Next slide, please. So implementing harm reduction in primary care. It's very important to provide current, accurate information about harm reduction principles, practices, and support to address the diverse needs of various target groups. Provide opportunities for training and professional development for your staff and the community service providers that you work with. Now, on September 21st, 2021, the Alberta Medical Association joined with the Canadian Medical Association, the Canadian Nurses Association, and the World Health Organization to endorse harm reduction strategies and tools. Dr. Paul Boucher, AMA president at the time, stated that offering Albertans evidence-based harm reduction interventions, including take-home naloxone programs, needle distribution programs, and supervised consumption services, constitutes part of a standard of care for opioid use disorder. Next slide, please. So here's some key messages. Recognize the value of harm reduction as an important and vital component in the recovery continuum of care. Keeping the patient safe, alive, and healthy provides them with hope until they can seek recovery. Acknowledge that stigma prevents people from accessing necessary healthcare services and prevents follow-up when a person fears they will face stigma once again. The Harm Reduction and Recovery Primary Care Learning Module suggests the following strategies. They suggest starting with a warm introduction. Shake hands, introduce yourself, maintain eye contact, remind the patient that you are very glad to see them there. Assess their story. This is maybe a complete history or a psychiatric history, their life story. We're talking about the trauma they've experienced if they wish to discuss this. But ask the patient to educate you. They become the expert. What are their goals? Next slide, please. Here's some more patient messages. Feeling validated is so important. Serious health issues are often left unchecked for years due to stigma and branding as an addict looking to get high. You can be their light, their guide, and give them their life back. A patient said to us, "The first day I walked in, I felt validated. So many healthcare professionals are dismissing me or just branding me as an addict only looking to get high in the past. My numerous health issues were left unchecked for years because I could never get them to listen. You gave me my life back." Next slide, please. Here's another patient's message to us. We are people too, not just throwaways. Maybe not what most people expect, but we are lovable, kind, honest, and down to earth. A lot of us have been through hell and back. We just want some peace and a safe place. Every single one of us is a daughter, a son, a sister, a brother, a husband, wife, auntie, uncle, mother, or father. We all belong to someone. We do matter. And this was from a patient named Amanda. Next slide, please. Just a final thought to consider. Doing nothing for others is the undoing of ourselves. We must purposely be kind and generous, or we miss the best part of our existence. And that's from Horace Mann. So thank you very much, and I look forward to your questions.
Thank you so much, Diane. And Jess, if you can steal the share, you're next up. Thanks.
All right. Thank you so much, Diane. That was fantastic. And I love your voice. It was so calming and lovely. I wish that I could have a nice calm voice. I've been screaming at my children periodically while you've been speaking. So if I do apologize if you hear what sounds like, I don't know, a cat being murdered. It's my children upstairs. But thank you so much for having me.
Sorry to interrupt. If you just want to switch your slides over, we just see
Oh,
your
did I do them?
background.
No. This one, swap displays. I've never presented on Zoom before, just kidding. Okay, does that look good?
Looks great.
Yay.
Yeah, it's good.
All right. Well, let's continue on. I hopefully have met many of you by now, but my name is Jess Kirkwood. I'm a family doc, and I haven't been fired from the Bowen Macaulay Health Center, which I worry that people will think, but we did change our name to Radius Community Health and Healing. No, we weren't bought out by Big Pharma. We just got really tired of being very confused with different Boyle named organizations and finally decided we'd do something about it after 40 years of that having that name. So that's where I work. And I do accept money for speaking. And so I only take money from 4-letter acronyms, as you can see on the slide. I'm just kidding. But I do take money, which has been from the Canadian College, the Alberta College, the College of Physicians and Surgeons of Saskatchewan, and the peer team. And I am a salaried employee at the U of A. And we had this slide that had this bright yellow highlighted thing. So I just felt like I should put something in there. And I don't really have like financial conflicts of interest or things like that, but I do have personal biases. And they include the fact that I think primary care is the best. And I think we can do absolutely anything. And I do believe that people who use drugs deserve the same, if not better care than every Albertan. And so that hopefully will come through tonight. And I'm not ashamed to say it. And then this slide also just talks about biases, but I'm going to keep rolling just to come right off of that excellent description of what harm reduction is. I had spoken at the Family Medicine Summit last year, I think, on the same topic, and being from the peer team, this is evidence-based stuff, and some things like could be taking a bit of NSAID, a bit of food with your NSAID, for example, or maybe putting sunscreen on your next tropical vacay. Hopefully with March break, people have plans for that. Wearing a helmet while skiing or snowboarding, like me and my daughter here, and maybe putting on your seatbelt while you're driving. And so then the types of harm reduction that we're talking about tonight remains an evidence-based, client-centered approach. We're talking about things like providing naloxone kits. We're talking about providing safe injection supplies, maybe wearing a nicotine patch instead of smoking, or to smoke less, and maybe having a few drinks of water around some drinks of alcohol. And I bring up these things because I don't know when harm reduction became this really bad taboo thing. And I know that if you're here on a Thursday night to a harm reduction talk, then you're probably not the person that needs to hear this message. I think that you're probably here to learn how to incorporate this in your practice. But just to pause and think for a second that me being a middle-aged white woman, if I develop a strong interest in wine, I'm cultured, and I am, all kinds of wonderful things. But if one of my patients develops an interest in alcohol, well, they're a drunk or an addict. And does that have to do with the activity itself? Is that because of the color of their skin? Is that because of where they live, or how much money they make, or if they don't make any money at all? And so I just, again, you're not the people that need to hear this, but golly gee, I just wish that we could stop villainizing things like harm reduction in certain circles. So we got a few questions before this awesome panel tonight. And one was this, which I love. I work in a pretty regular suburban family practice. What do you suggest on having on hand for harm reduction? And how do I let my patients know about what's available? And I love the things that Dianne said about just the patient interaction and how to be this caring person, because I could tell you to have like a room full of clean injection supplies. I could tell you to have posters galore and pamphlets, but if when you're in the room with a patient, they don't feel that they could safely talk to you about their substance use, I don't think those posters and pamphlets and supplies are going to do a lot. And so I'm going to just talk a little bit about what we need to do to make this an open environment. And so the first is screening. If you don't ask if someone is using any substances, you're not going to know. And I have touted time and time again that I'm a simple person. I like simple things. So if there is a single question screening out there, that's what I'll use. I don't need to have some big scroll or form to get people to fill out. And this is a validated screening question, and I'll talk about what I like and what I don't like about it. How many times the past year have you used an illegal drug or used a prescription medication for non-medical reasons? Anything other than never is a positive answer. That doesn't mean you need to sound the alarm or immediately shove Suboxone under their tongue, buprenorphine, naloxone, my apologies. But this is a validated tool, and we've looked at primary care, and we've compared, I'm not a part of this study, but people have compared it to much more in-depth substance use, or even doing oral fluid testing. And they found that this single question was 100% sensitive, meaning that if somebody said never, that was pretty reliable, and 73.5% specific. So you're missing some people in there, but you're catching a whole bunch. And again, if you don't ask, you won't know. So what do I not like about it? Illegal drug, used prescription medication for non-medical reasons. I think we need to remember as primary care providers and healthcare providers that we are in a place of authority, whether we feel that way or not. I don't think I should be, but if I'm using words like illegal drug, how much is a patient going to be like, yep, that's me? Maybe not. And so I use kind of a less judgy version, is what I've called it. So many of my patients use substances to cope with everyday life. In the past year, have you needed to take or buy something for a non-medical reason? And change that as much as you want, because mine's not validated, but it works. I get to find out what's going on. And I think that if I'm able to do that in a calm, respectful, open, honest, kind way, that I'm going to find out what's going on with my patient, and that they know that I'm asking because I want to help them, not for any other reason. One question we got was, are there any suggestions for crystal meth harm reduction? Are there medications that would help people decrease their use? So I did do a talk on stimulant use disorder for PIPE this past year. And I confirmed with Kathy, I don't think the CMN has done a talk on this specifically. And if that's something you'd be interested in, by all means, let the CMN know. But I do think that there's some big things that we can talk about before we even get to things like pharmacotherapy for this particular substance use. And so I made a little algorithm. Up here, we like to really try to simplify things. So we take systematic reviews with thousands of RCTs and turn them into a one-pager. And I tried to make this very complicated topic a bit simple. It's still going to be complicated. We'll need to take a pause at the end, but do you think somebody might have a substance use disorder? Ask them, like I said. And if they say no, but you still maybe really strongly suspect that might be going on, that's okay. Acknowledge their answer. You may want to conversationally bring up things about harm reduction or poisoning prevention, in terms of I don't know if you're aware, but there's a really highly toxic fentanyl supply and opioid crisis that's happening right now. I'm losing a ton of patients to it, or as Albertans, we're losing lots of people to it. So if that's ever anything you think you might encounter, please know that I'm someone you could talk to. This is a safe space to talk about that. That's really all you can do. If they say yes, kind of doing the same thing. Acknowledge that answer. Thank you so much for sharing that with me. And then going into a little bit more, if they're open to it, about harm reduction or poisoning prevention. And so that may be if this is a patient who has access to a safe consumption site, or you think could benefit from that, talking about where these are located if you have them in your city. And we know that we live in Alberta, and so some very, very highly used safe consumption sites have been closed in Alberta. So this isn't something that is available for everyone. And I know that if we're talking about maybe a general family practice, maybe your patient wouldn't feel comfortable going there. We do have a national phone line that patients can phone. I meant to squeeze a slide in somewhere and then it just totally slipped my mind. So I do apologize, and I'll put links in the chat when I'm done. But NORS, the National Opioid Response Service, I believe, is a phone line where if a person is using something, they give permission to have EMS dispatched to them if they become unresponsive. It was developed by Dr. Monty Ghosh out of Calgary and a team there, and they've saved lives with that program. In Alberta, we also have an app. I think that alone indicates that someone has the privilege to have a phone, but it's something, and an app would be great to also tell your patients that do have a phone that same sort of thing. If they become unresponsive, they've given permission for EMS to come to make sure that they're okay. And then just identifying your practice as a safe space as well, and saying, you know, I'm here for you, I'm here to help you, things like that. Moving on from there, before we get into, you know, pharmacotherapy and all that, does your patient have access to shelter, food, finances, supports? These are really, really big things, because if we're jumping into, you know, talking about treatment centers or where they can go for group counseling or something, we're kind of missing the boat. And a lot of times certain substances can be used as a completely life-saving protective mechanism. I have many, many patients that will use a stimulant such as crystal meth to stay awake during night because it is unsafe for them to fall asleep somewhere. And then they can go to sleep somewhere safe during the day. If I was to just be like, how are we going to get you off that meth, Susie? Susie, I'm taking away her life preserver, and I'm completely missing the point as to what's going on. And so I've lost her, and really we need to just focus on these really basic things that can be a huge factor in terms of substance use. If patients don't have these things, then that's what we're going to focus on. We're going to focus on life-saving harm reduction, like an naloxone kit, like the stuff I've talked about poisoning prevention, but then we're really going to try to connect them with social work. If they aren't working, which is, we're seeing that, you know, many of Albertans that are dying from poisonings are people that were working, that were highly functional, that were using in secret. So we need to say, hey, we need to get you time off work. How can I write a letter to get you some time off work? What can we do? Giving them letters for financial assistance. So applying for AEII or Alberta Works. If, you know, at any point, if internally you've clutched your pearls and like, oh, Jessica, what if they use that money for drugs? I need you to just let go of your pearls for a second, because we have really good evidence that shows if we give people money, they do good things with it. And we have studies that have shown that if we just give people money, they will buy food and clothes and housing. And when we follow up later, they are doing better. So don't worry. And it's their money. They can do whatever they want with it, but you can help them to become more stable. Okay, if they do have shelter, food, stable finances, supports, all that, the next step is, do they want to cut back or stop? Are they, you know, and just like I talked about, if I'm going to just jump to how are we going to get you off this, we need to stop and talk about what are patient-driven goals. How are you feeling about what's going on right now? And how can I help you reach your goals, whatever they may be? If at that point, where am I going? They say no, respect their decision. I think that's so huge that, you know, we can't possibly understand what's going on with someone, but if they have clearly told you something, we need to respect that. You can ask for permission to say, you know, as your family doctor, nurse practitioner, whatever role you might be in, I have concerns about your substance use for these reasons. This is what I'm worried about. You can absolutely do that. Please feel free. And if they say, yeah, sure, I'd love to hear about it, go for it. They might already know. To be honest, they've probably had people barking at them for a long time. And so adding into that may not be helpful. And continue to provide care in whatever it is. What brought you in? You know, I'm not going to completely disregard your festering wound or your big swollen joint or whatever it is you brought me because you've told me you use meth. We're going to take care of both. And then remind them that if they've said, no, I'm not interested in cutting back or stopping or anything, you can just say, well, my door is always open if that changes, and I'll still continue to see you and provide you care if you're using substances or if you're not. I think too many times that door is completely closed for people, or they're told that whatever their issue is, it's due to their substance use, and then they just don't want to seek care anymore. And that's so sad. If they do want to cut back, well, then we're going to go into this sort of menu of options that we have. And we talked about this when we did a talk on alcohol use disorder and pharmacotherapy for alcohol use disorder, but really looking at your local supports might be available. There's obviously lots of non-pharmacologic things in terms of treatment, counseling, meetings, groups, things like that, as well as if things are appropriate, accessible, and safe, looking at pharmacotherapy. And again, this really won't be a talk where I can get into everything about that. And it is totally, totally okay if this is way, way outside your comfort zone. I know that, you know, the demands on primary care are so extreme, and it's totally okay to say, yeah, and probably your patient, if they've been coming to your clinic and they can look around, they may think like, this person's not going to know what to do with me. It doesn't really matter if you know what to do. It matters if you care enough to learn with them. I remember the very first time I started hormone therapy with a trans patient, we sat together and we did it with the guideline, and she said, I really feel like we're doing this together. We're learning together. And I was like, well, that is because we are, hon. Like, here we go. And that was great. And you know, years later, I feel way more comfortable. But honestly, that patient, they didn't think they got a dud. They thought they got somebody who cared, and they did. I did really care. And I knew it was going to take way too long for them to get what they needed. So why don't we figure it out together? Oh, did that feel simple to you? It didn't, probably. And I'm sorry, it's a lot. But we do need to just remember that kindness is doing what you can, where you are with what you have. And it's okay to not have everything. It's okay to struggle. Okay. It's also okay to feel like you're this person staring at a brick wall. We have so many boundaries and or barriers that are preventing us from doing this care. We have time constraints, we have financial constraints, we have, you know, we don't need to get into how overburdened we all are. And sometimes you just want to take your perfectly coiffed hair and smack your forehead against that brick wall, and that's okay. And that brings me to something that I was supposed to discuss tonight called the narcotic transition services. I will state right off the bat, these are my opinions alone. You're not hearing the opinions of my clinic, my colleagues, my university colleagues. This is just what I feel and I think about what's going on. And I would love for us to be able to have some time for discussion. So this is just seriously a screenshot from the PDF we got back in the fall, if you're not as familiar with it. At that time, we were told that Alberta Health Services physicians are going to be the only people, and nurse practitioners are going to be the only people that can prescribe hydromorphone, diacetylmorphine, and fentanyl for patients with opioid use disorder. That got a little confusing, I think. Obviously, those three medications aren't first line, right? We know because we've all been to so many workshops, and you've heard me talk my head off about OAT, that things like buprenorphine, naloxone, or Suboxone in its various forms, things like methadone, things like sustained release oral morphine or Cadian, those are our first line therapies. But first line therapies don't work for everybody. And so I know in my practice, I have a small handful of people that have failed those first line therapies time and time and time again. And quite frankly, I'm not comfortable sitting by and waiting for them to be yet another poisoning death. So I have patients that I have, yes, I'll say it out loud, I've given hydromorphone to. And you know what? Some of those patients have done really, really well. And I have a very small number, but I have patients who are on like smaller dispenses of hydromorphone, who since getting hydromorphone, they've done urine toxicology screening that has shown no fentanyl. They have had no further poisonings. They've, you know, got stable housing. Gosh, one of them got a job. Excellent things have happened. So I was a little shocked to learn, because I am not an AHS physician, that I'm not allowed to prescribe for that patient anymore. That was a bit of a, ooh, really? Okay, won't that be disruptive to their care? We learned that only the narcotic transition services physicians or nurse practitioners can initiate these things and can continue these things. And really the best effort is going to be made to put them on an evidence-based medication such as Suboxone or Sublocade. We just went straight for the trade names there, as soon as reasonably possible. Okay, don't get me wrong, you all know I love Suboxone so much I feel like a Suboxone rep sometimes when I'm talking about how great Suboxone is, but that doesn't mean it works for absolutely everyone. That was a little troubling, a little concerning. And I love the bottom. This does not apply to treating chronic pain or other illnesses. Nope, not at all. Okay, that made me do one of these. And that's all I'm going to put in writing is this giant thinking emoji, but I'll tell you what I think and I'll tell you what's happened to me so far. I'm such a positive person. If you've met me, I really, really, really try to be a positive person. So here were some good things I thought. I thought, they've been threatening to close IOT and closed IOT at various points. There was people that were forcefully transitioned off of IOT that have died. And there was the whole lawsuit that Dianne spoke about. So maybe this is like a string to give people access to IOT. Okay, that's positive, I hope. So that was one thing that I thought. What was my other? I had two. I already forgot my second positive thought, but that was it. And then I really, really struggled this because is hydromorphone, diacetylmorphine, and fentanyl prescribed? Is that what's killing people? Well, no, we know that over 90% of our opioid poisonings are caused by fentanyl that people have gotten off the street. We know that from their toxicology reports, postmortem. Why are we focusing so heavily on these three medications? And why are we only allowing a certain group of physicians to prescribe these? I have a colleague who he used to train everyone in the province to say if you could prescribe methadone or not. He's not an AHS physician. He doesn't know who failed first-line therapies. That was confusing to me. And don't we have an overburdened system? Like, do we have a wait list that we're now extending with this? I'm coming close on my time. I thought I'd be better at this, but I should have known. The thing I'll say is I had a patient recently who, pre this whole thing, it absolutely qualifies to try something else. He has failed first-line therapies time and time and time again. But because there's been so much uncertainty around the NTS, I didn't feel comfortable starting him on a medication that I thought potentially could have been stopped. And I told him that. I said, honestly, I think this is appropriate. I think that you would be a perfect patient for this, but I'm really concerned because there's been not a lot of clarity around what's going to happen to you or me, that if I start you on this and you have a well-documented history of opioid use disorder, that you could be stopped abruptly and that could kill you if you then return to using. And that patient got really mad, rightfully so. The patient got so mad that he's threatened me several times. I've actually had to put a policy in place that I can't see that patient in a room with closed doors. And that sucks because that's not how I practice medicine. I don't have patients that I don't feel safe around because my patients aren't scary. But a ill-informed policy caused that disruption in care and that disruption in my therapeutic rapport. And that sucks. And I think that we're punishing the wrong people. We're punishing people who can accurately diagnose their patients with opioid use disorder, and we're punishing patients that have really tried. So that is what I've got on that happy note. I'm sorry, minute and a half over on my screen, probably more on others, but I am so excited to hear our next speaker. The first time we met years ago, I told her I loved her, and that continues to be true today. So I will shut up so we can hear Kristy Sutherland speak. Thank you.
Oh my gosh, you're a tough act to follow. I'm sort of tearing up at all of the presentations so far. Okay, so I'm Kristy. I'm a physician here in Vancouver. For my financial disclosures, it's working in the downtown east side, basically, like a changes person. Sometimes I go and do talks and people are like, no downtown east side thing. So definitely I've been in the downtown east side 13 years. So that's changed me as a person. I take no money from pharma or industry, but I give a lot of talks and so get payment from that, but never any pharma money. So this past year, I've been doing a lot of thinking and I've been doing a lot of overdoses. I don't know how many of you guys have done an overdose intervention. I'm not very good at acute medicine. It's why I do community primary care, but suddenly I've become an expert at codes, but only if it's an opiate overdose. And every time I would do an overdose intervention out on the street outside my clinic, I would think, oh gosh, if only I could go back 10 minutes and give this person different drugs, then they wouldn't have overdosed. And then you think, oh, okay, well, if only I could go back to the 80s and have them not be abused as a kid, or back to the 60s and not have them stolen from their family. Or maybe we need to go back more than 100 years and think about how did we get here? So that's really what I've been thinking about this past year a lot. Because we're seeing this increased potency and increased contamination of the drug supply and increased death. And why? Why are we here? Why is this the system? And that the baseline for society is that drugs are not always illegal. That is actually pretty new in Canada, relatively to the history of the world. It is expensive. Drug enforcement costs billions of dollars, and that most of arrests for drug possession in Canada are still for just personal possession. It is not the big time drug dealers that are being arrested. And drug supply, drug distribution, and profit from drugs is controlled by organized crime. So here is a U-shaped curve. Love a U-shaped curve in medicine. So right now, so this is health and social harms, and then different frameworks for how drugs and society interact. Because drugs exist, like that the UN is looking for this drug-free world, but that is magical thinking. Like drugs are a thing, they always have been. But it used to be that you would smoke opium, and now we're injecting fentanyl or carfentanil with Sutherland. So how do we get there? Like, so if you were to take a blank Word document and write the worst approach to drugs and society and their relationship, you would write what we have right now. So this is unregulated illegal profits. So organized crime is killing people for money. It's like any multinational company. They are not ethical in terms of their environmental stewardship, in terms of how they treat their employees. They're not paying overtime or pensions. They're instead murdering people, right? So we don't want to be there. Like, I would like to not be in this system anymore. I'm sure we all do. The other side of this U-shaped curve is unregulated legal profits. So this is like tobacco in the 60s and 70s, saying that they have nothing to do with lung cancer. Joe Camel, if you look at magazines from the 80s, there's tobacco advertising. I would say right now for tobacco and alcohol, we're down here. We have not optimized the public health interventions for these two drugs that do cause harm. I think that there should be standardized labeling for alcohol, no sort of attractive, person on a bicycle or whatever, all of the beautiful alcohol labeling, or like no alcohol column in the Globe and Mail for the sommelier, that we could regulate alcohol and tobacco much more to decrease morbidity and mortality. But where we want to be for drugs is at the bottom of this U-shaped curve. And that's a public health framework for how drugs and society interact. And that we want the least amount of harm to the individuals that we care for, and we want the least amount of harm to the public. So going back in history for Canada, that Vancouver was actually the birthplace of prohibition in Canada, and largely driven by anti-Chinese racism and a perceived threat to white middle-class purity. So there were riots in Vancouver in 1907. Thousands of white people went into Chinatown and they destroyed businesses and homes. It made international news. And a delegation from Ottawa came and they interviewed people to ask what caused the riots. It was mostly white people that they interviewed, and they said that the riots were caused by opium. This delegation returned to Ottawa and they passed without any debate the Opium Act of 1908. So that's the first time that drugs became illegal in Canada. And that was like the tipping moment for things getting worse and worse, because we can mark over the coming decades the shift from smoking opium in a family-owned business to injecting carfentanil with Sutherland. It's driven by prohibition. So Canada has really harsh drug laws, harsher often than when compared to our neighbor internationally. And each of them encompass more drugs, pro-drugs, and the supplies to create illicit drugs. When we're thinking about drug policy, it's quite complex, because often when people think about drug policy, there's no document to read that's drug policy in Canada, because it bleeds into so many areas of life. Like, we think about it as just justice, but it's also housing, shelter, and social policies. I can think of patients who don't want to go to shelters that require abstinence because they'll have a seizure. So they're sleeping outside and able to drink, so not having a seizure, but dying of exposure or violence, or sleeping inside and seizing. Like, what a terrible choice to make. Resource allocation, city planning, health, school planning, work safe and employment. Like, I've done expert reports about safety sensitive positions and urine drug testing on the job. That drug policy just, it is pervasive. And so it's so complex then to try to tackle it to make it rational and evidence-based. But what we can say is that if you use drugs, the outcome of your drug use is largely determined by your race, gender, wealth, social capital, health status, purity and strength of the substance, and if this is known, and the context of where you use. So all drugs carry risk, those that are legal and illegal. And if we were to divide up what should be legal and illegal based on risk, we would never pick alcohol and tobacco, the two cancer-causing agents, to be the ones that are illegal. But I can drink fancy martinis at Shambar while my patient is overdosing on fentanyl meters away. So alcohol prohibition is famously a terrible policy. And to me, this is what we are in right now for opioids. I don't know who today's Al Capone is. There he is, 27. He was worth $1.4 billion in today's dollars, went to jail for tax evasion. to think of all of the murder, all of the organized crime profit, all of the blindness and harm that went from non-beverage alcohol. It only lasted for about 10 years in the States, but it is famous for what a disaster it was. I think that today's Al Capone is living in West Vancouver in a mega mansion, and that he never comes to the downtown east side to see this devastation. But people in organized crime are making billions of dollars off the suffering of Canadians, and it's due to our lack of regulation. Here's John Ehrlichman. I first heard about him in a podcast I listened to about Watergate. He actually went to jail for Watergate, and he was one of the top advisors to Nixon. And in 2016, Harper's Magazine did a history of the war on drugs, and they went to Ehrlichman's house, and he didn't really want to talk, but the reporter sort of stuck his foot in the door, and this is what Ehrlichman said. Do you want to know what this is really all about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and the Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Do we know we were lying about the drugs? Of course we did. I thought that this would be a change moment in drug policy. When the architect of our war on drugs says we did it because of racism to get votes, like you think that we would have some change, but no, things have mostly only gotten worse. In Canada, we are not exempt from all of this terrible, like racist application of these laws. That historians have demonstrated that drug law in Canada has not been a benign phenomenon aimed at safeguarding the health of Canadians, but a tool of social control directed unevenly at some groups of people. So it's billions of dollars of profit. This is probably an underestimate. It goes through the dark web, and it's through Bitcoin. So you can imagine what the profit margin must be if killing your customers doesn't decrease your profit. And to contrast that with, I remember 10 years ago when I was a new family doctor, that it was heroin, but that heroin has to be grown from poppies, shipped internationally. You're paying off people at every border, at every port, murdering people along the way, and then your shipment might never arrive. But fentanyl comes in the mail, in a printer cartridge. And that if with the dark web, there's an escrow process where a third party holds your Bitcoin, your fentanyl arrives and you test it and you say, I'm happy with this fentanyl, and then that money is released. So the profit margin is so high. So many murders, so many disappearances, and yet drugs are easier to obtain, they're more potent, and they're cheaper than ever before. This is from Twitter. Like, I am really trying to focus my time this year on thinking about these structural problems and not burdening my patients with making different personal choices. That my patients are trying to navigate a system that is violent towards them, and that this is actually a structural problem. And I think about non-toxic drug supply, so consumption in a safe space. So I think about my life a lot when I'm thinking about what I want for my patients. I have a door that locks, there's no violence in my household, I have clean water, I have safety, and when I drink alcohol, I know what's in it. So let's talk about decriminalization versus legalization. This is an important distinction. It was one of the pre-questions for this talk. That decriminalization is basically paperwork. It is removal of criminal penalties for possession of drug use for personal use. So you're just decreasing scope of practice for police. You're saying don't arrest people for this. People have said Vancouver has been decriminalized for years. It's a bit more nuanced than that, in that people have not gone to jail for drug possession, but often they're picked up, they're charged, it goes through a court system and then it's dropped. So it's still a huge expense to the court system, a huge amount of time for that person. I'm so glad that with this decriminalization, it's the 2.5 grams and not discretion, because whenever you have discretion with who to arrest and not arrest, then racism gets into the picture because of systemic racism in policing in Canada. And so it's great to have a cutoff, but then it sort of speaks to the futility of the war on drugs, because 2.5 grams of what? Of pure fentanyl, or there's something called the Hastings Special that is 10% fentanyl. So that's a huge range of fentanyl that you can possess legally, that it sort of becomes nonsensical. For legalization, that's drugs available for purchase. And there is a wide variety of options for how this can look. Like, people always jump to the liquor store to say, do you want cocaine available in the liquor store? No, like I don't, but I think it would be better than what we have now with people being murdered in Colombia and like having it shipped in these unethical ways with, you know, terrible environmental devastation, and then people sort of injecting it in the alley. Like, I think there's something in between there. Ryan Marino is a great person to follow on Twitter. And this little graph really struck me because it's people who use drugs and people whose drug use is criminalized. And this is basically my social life. So I think about all the people I know socially who have used drugs, like camping trips, my grad trip, parties. Like I know a lot of people who have used drugs for a good time. 0 people in my social circle have ever been arrested for drugs. But I think about my patients, and that's people whose drug use is criminalized, who are arrested over and over for possession of drugs. So decriminalization is not like opening the door to like a hedonistic party. It's just to give the privilege that I, as a white person, have had my whole life. It extends it to other groups that legally they can't be arrested for something that I was never being arrested for in the first place. This was a real moment for me. So Donald McPherson is the head of the Canadian Policy Drug Alliance. He's now retired. And I, in my wisdom, when cannabis was first becoming legal, said I thought that the legal age for cannabis purchase should be 25, because that's when your brain has started, finished the development, and I worried about youth and psychosis and, cognitive function. And Donald was like, oh yeah, totally, Kristy. No, we do not want youth initiating cannabis. Yeah, it would be great if everyone did no cannabis use until they're 25. But it's not who you want using or not using. It's who do you want to see criminalized. And I, like, the penny dropped, where I was like, I can both want cannabis to be legal, and I can want people to not be arrested for using cannabis. And at the same time, I do not want youth to initiate cannabis. Those are not in contradiction of each other. That taking away the criminalization basically takes away oppression of Black and Indigenous people. And that we can do other things, especially as physicians, that protect youth from initiating cannabis use. And so teasing those apart in my mind to say that criminalizing things is not the mechanism to decrease drug use that we think it is. So Stopping the Harm is the Dr. Bonnie Henry report that reviews the evidence for decriminalization. Portugal famously decriminalized in 2001. I'm conscious of the time. They had quite good outcomes. More than 25 countries worldwide have eliminated criminalization. The challenge with decriminalization alone is that you have no control over the supply of drugs and the harms from the supply chain, and you have ongoing profit to organized crime, and you have tax revenue. So it really is only half of the picture. And when we think about what brings safety to a system, like I think about this train derailment in the States right now, that like you want standards, inspections, licensing, taxes, audits, you want limits on who gets the profits, advertising, marketing, packaging, price controls, driving restrictions, bylaws on where use can occur, where it can be sold, age restrictions, and limits on amount that can be purchased one time. If we applied these to the maximum for alcohol and tobacco, we would be safer. And I would love it if my patients could have this applied to their supply of fentanyl, that we would have less death. And what I like to point out on here is that physicians being psychic or physicians being gatekeepers to opioids is not on that list. That is not something that gives a public health framework of safety to a system. So if there was a winery that was poisoning people, our expectation would be for the government to go and shut that winery down. We would not expect the government to say, okay, now alcohol is free, go see your family doctor, and your family doctor is going to dose you on alcohol and give you your free take-home alcohol dosing. It's going to be daily dispensed at the pharmacy. Like, I've done a lot of safe supply prescribing over the past, since 2016 is when I started my IO program, and then we started take-home hydromorphone in COVID. I've done a lot of it, and I'm sick of it. Like that, it is a medical solution to problems that are created by the criminal justice system, and that I want a solution that addresses the upstream cause. Like, I don't want to be writing these prescriptions for my individual patients. Like, it's like swimming upstream. I want the government, and it's like also terrible, and the government's funding me to do this, but they're also funding the problem. I get salty. So I wanted to create a legal regulated market, basically. So it's a whole other talk, but I created a compounded fentanyl powder that is equivalent to the fentanyl sold on the street. It's injectable and smokable, 20,000 micrograms of fentanyl per capsule, and I'm selling it at the street price. And I had the college librarian do a literature review that's the price is a key point in safety for the public for how much people use. The WHO has called for minimum alcohol or mandatory minimum alcohol pricing internationally. And we know that when there's happy hour bylaws, that there's a limit to how many drinks you can buy and how many shots can be in a cocktail, like that these things provide safety. So my goal is to provide this lens of safety to drugs that I can prescribe for my patients. And it's important that these systems exist in parallel, that I send my patients to recovery all the time. And I think that everyone can get better and everyone can be abstinent if they want. But I don't think the tool to get them there is criminalizing them and forcing them into this dangerous circumstance of having to go to this drug dealer on the street corner and to get contaminated drugs. And then I would like to talk about prevention. It's all caps here. My cat was walking across my keyboard and made it all caps, but I thought that that was the slide format for the Alberta. And I was like, okay, all caps, let's go. Prevention is really complicated because basically you need the time machine. We want to reduce adverse childhood experiences. We want to provide people with safety, with access to their culture, to sports, to food security. That these are the things that decrease drug use. It's not as simple as telling people just say no or having a police officer to go to school. Like if it was that simple, people wouldn't use drugs. It has to do with so much more to unpack. And that if prevention doesn't work, you shouldn't have death as the next step, right? Like I think about the weddings that have happened in Kamloops where like 4 people died. Like prevention didn't work. They used drugs in that wedding and then there were 4 deaths. Like how heartbreaking. And so if prevention doesn't work, then we need something that is more reasonable than being poisoned and dying on the street. And that's it. Sorry to like buzz through so quickly.
Well, thank you, you three all. Lots to think about. I know that we had put out a call for questions and most of those have been answered. And certainly, Kristy, when you were talking about racism as a root cause, yesterday we had, no, on Tuesday, I guess, Minister Copping talked about the modernizing of Alberta's primary care system, and the Indigenous panel reported the Indigenous life expectancy in Alberta is now 18.1 years less than a non-Indigenous person. And one of the primary reasons is drug poisoning deaths. And in my zone, we have the highest. I'm down in South. But it's heartbreaking.
It's so sad. And that it's the same in BC that Indigenous people are so overrepresented, and that I don't remember off the top of my head, but it's another slide I have, if you guys have me back, that like in 2017, so the year before or 2 years before cannabis became legal in Canada, when we look at criminal charges for drug possession, I think like 16% of people charged with cannabis possession in Vancouver were Indigenous. Like, how can that be anything other than racism? And then how can we say it's a reasonable system? Like when we can see the outcome is just a racist application.
Yeah, exactly. I don't know if anyone, I can't see hands, but if anyone has a question or wants to comment, Janelle.
Hi. So my name's Janelle Siring. I'm a family doctor in Calgary. I'm Métis. I'm originally from Treaty 1 territory, and I'm a graduate of the UBC Indigenous Family Medicine program. So I did my training in the downtown east side at Chiway and Vancouver Native Health and Kalalalem and Kalima. And I went out there because I needed to get the skills in serving my people. So I've been back in Calgary for just over a year because this is where my husband has his job. He's a surgeon here. We came out here from Ontario. It's been pretty horrifying, bearing witness to what our government is doing towards people who use drugs, especially Indigenous people. So we have an election in May. What do we do? This is horrible. Like, this makes me so angry and upset. Like, and it's affecting my people. Like, what?
Yeah.
Please help.
Well, I think it's such a good question. I feel you, and my heart goes out to you. Like, the loss is profound, and like I can't. You know, as family doctors, I think we also feel this in a different way, because I can't tell you how many times I'm going to start crying too, that like I'll get a little reminder in my EMR that someone's due for their PAP and then they're dead. Like, how many times has that happened to me? And then I start to tear up and I'm like, okay, next patient. You know what I mean? Like, that we just keep working. But I think like a legal regulated market is the pathway out of this. Like, a program will never solve a problem that's created by policy. A librarian friend told me that, and I almost collapsed because I was like, oh, my whole career has been creating programs. But I'm trying to solve policy problems. Let's say I get 100 people on my fentanyl patch program. That's 100 people who are doing well, but I'm not solving the war on drugs that our Canadian government is perpetuating that is causing this death. And so I've created this legal regulated drug market. I actually regulate myself in my drug sales more than is required by my colleges. And I am so happy to help other programs set up sales because we are physicians. And so the same way I go to my family doctor, I get a prescription for Ventolin and I go to Shoppers Drug Mart and I pay for it. It's that framework for drug sales. And so people can have take-home doses. There's low risk of diversion because they're buying it at the same that it's for the street value. There's no incentive to buy on or to sell on. And that you buy however much you want to use that day. Like there's no stockpiling because then you're just spending more money. And so I do lots of consulting to help people set it up. And I think in a context where the government is hostile to it is actually a better place to do it than BC, because my challenge right now, if you can believe, is that the BC government wants to cover fentanyl powder so that it's free. And then I can't do the sales program. And what they sneakily do, they've done this for heroin, is that they cover it and then cap it at 200 people. So then you're stuck like 160 people die a month, right? Like, how are we still pretending that we're doing anything if we're doing programs that only reach 200 people? And that people need take-home dosing. They need to use at 3 a.m, but I don't want to give take-home dosing of free drugs because I think that that's a recipe. Well, it's not gone well in the downtown east side in terms of diversion and movement of this drugs across Canada that we are prescribing. So get your group together and consult me. I'll share all my policies and procedures, all my templates, all the legal review. We had hotshot lawyers at RV Finley. We've meet all college regulations, federally and provincially, for pharmacists, physicians, and nursing colleges, and set up a sales program. I'm working with a pharma company that is working in Colombia to get ethical cocaine because Colombia has declared they're no longer going to enforce the war on drugs because it's caused so much death and torture. It's just been horrific for their country. And to think of all the injustice to supply countries over our ongoing demand for drugs and our punishment of those countries, that I want ethical cocaine, and that we are physicians, we can write prescriptions for cocaine. And then we can regulate ourselves and say that cocaine costs $15 for a line, and that this cocaine, no one was murdered on the way. No farmers, no Indigenous farmers had their land stolen in Colombia to create this cocaine. And I want to do the same with psilocybin and ketamine. Anyway, I'm dreaming big, but that sometimes having a more reasonable government, because my provincial government still doesn't support my program. They'll sort of be like, "Oh, Kristy, you're just such a nice person." And I'll be like, "We're recording, so I won't say what I think in my mind when I talk to them." But that, governments can be supportive in a way that still really undermines you. Anyway, that's my ramble.
Okay, so who from the ACFP, let's do this thing.
Yeah, that's me. So
Okay.
Dianne will connect. Dianne,
Okay.
Dianne and Jess, I just want to get your comments on that.
I don't know, Janelle, I cry with you. I can't, I can't hear of another patient dying, but yet I will when I go to work tomorrow. And so I have sorry, my dog's having a fit in the corner. I have so much hope for May, and then I have so much fear. And so if you're asking how to mentally prepare, how to cope, I don't have the answer because I'm not sure. I look to stronger people. I don't know what the answer is going to be, and I'm really, really, really worried. I'm really hopeful, but I'm really worried.
Dianne, you're muted.
Yeah, I'm very hopeful, but as I listen to this tonight, I'm just really sad. And I was so sad when they were closing the eye clinics. You cannot imagine the tears and the anger and the number of things I did to fight. I went through everything from working with the finance people. I worked with everybody I could think of to prove that I should have stayed open. And it's when you heard all the stories of people that said their lives were changed, the mom's back with their kids, this guy's gone back to work, and all these stories from people that were just doing so well. And then I hear about the new program that Jess talked about, and I'm thinking, I hadn't seen that whole list before. And I'm thinking, that's not it. That's not it at all. And I mean, when I fought for IAT to open in the first place, I went and met with government. I remember some of my bosses at the time looking at me because I was definitely going there to get it all. I was not going there just to get a program where we gave people drugs and we treated them and all that. I wanted everything. I wanted social services. I want nurse practitioners. I wanted counseling. I wanted the whole package, or it wasn't going to work. And they heard me and I got it. And then to look back and think, how did we lose that? Like, how could that happen? Because that's what people need. They need the whole package. They need everything. And Jess, I loved your talk as you talked about housing and all the different things that are so incredibly important and game changers. So Janelle, I don't know what support you've got and who you can talk to about this to get the support you need, because I can only imagine what you're feeling.
Now, I know we're out of time almost immediately, so I'm sad to say that. Janelle, I don't know if you mind throwing your email in the chat, because I'd love to talk to you. And also, I suspect that there is some colleagues in Edmonton that would be interested in working on this very issue. Certainly, yeah. Oh, Maya's got your email. Sorry, we've got you. So I do want to thank all of you for your great presentations and the passion that you show. Thank you everyone for attending. If you have questions, please fire them in and we'll get them answered for you. The Narcotic Transition Services, I know the section of addiction medicine has put forth multiple concerns, and yeah, we're not getting anywhere. And so we need to approach it differently.
The only
Can
thing
I just want to say one thing about that is that, well, calling it narcotics, like it's not a medical term, but that transitioning everyone to oat, like I want all my patients to be on oat because their daily opiate users are at high risk of death. And we know that oat decreases mortality. Like that's our backbone for mortality reduction. But what about the construction worker who uses once a month? You're not going to put him on oat, right? How is he getting fentanyl that's not going to kill him? There's no medical intervention for that individual. The only intervention is a legal regulated drug market. And so to me, that's where I want to go. I'm working on expanding my sales program to community pharmacy partners. And then I want to find those people. I don't know how I'm going to do it yet, but like I'm going to find those construction workers and prescribe them fentanyl to go that they come and buy. And maybe they pick up once a week or pick up once a month if they're only using intermittently, and that they don't need methadone. It would not be indicated in that person. And that's often the people who are dying are not the daily users.
100%.
No, exactly. I mean, isn't it? I mean, it's close to 50% of construction workers, 35 to 50, using alone in their own home.
Yeah.
At least that's our stats. And these
Very
are
similar in
those that
BC.
are not, they are not using every day. And so, yeah, for sure.
The only thing I'll add, Kathy, about NTS that I meant to mention is every single one of my patients with that I've had on these, horrible drugs that we're not allowed to prescribe anymore, they have chronic pain. Of course they do. They live in chronic pain. I wouldn't want to live a second in their body. So if I have to lie about their primary diagnosis, I do not care. And that is what I've done, is gradually just transitioned everything. And I don't know, I guess I'll find out what happens. The next time I talk, I'm giving it in handcuffs, whatever.
Well, certainly, in talking to the architects of that, as long as it's documented as chronic pain on chronic opioid therapy, it sounds like we continue. But I mean, let alone look at our rural, remote, and Indigenous communities that weren't consulted at all on these kinds of policies. So super challenging. Just really appreciate everyone's time and passion. And I have two plugs. One is CMN Next is on March 18th. It's talking about wicked problems, basically, that we deal with in addiction and chronic pain. It's a free all-day workshop using human-centered design with Pivot Group. And if you guys know the Pivot Group, coming up with some solutions on how we can move forward in the things that keep us up at night. And Summit is next week. So that's a big family medicine conference, but it's open to all our interdisciplinary team members, and registration is still open there. So two plugs for some CPD that will be valuable for you. And I really appreciate all your time and effort. And I know we're a little bit over, but if there's any last questions, any last comments from my panelists, I would love to entertain them. Oh, Tanya. we've got a comment in this. I wanted to say that you were so brave, Dr. Sutherland, and I agree with your logic and your approach. If it was widely adopted, could potentially change the drug trade. Thank you for this talk. So that's
You're
great.
welcome.
Any last words of wisdom?
Call me. That's my last words of wisdom.
Yeah, that's great. So if I can remind everyone who's still on, if they can, fill out the evaluation. We look at these all the time, and so we'd really appreciate that. And the next slide, CMN Next, I've already plugged. And would be happy for anyone who's interested in coming out. And so next month, we are going to be talking about innovations in managing chronic pain. And we have some great speakers lined up for you. So hopefully we'll see you in a month's time or at any of these events. Thank you.